Today our topic of discussion is SIADH. SIADH, which stands for Syndrome of Inappropriate ADH Secretion. Why it is called inappropriate ADH secretion? Because normally serum ADH is a function of serum osmolality. In response to osmotic deviation, there is change in serum ADH concentration. But here in this condition, you will see there is increased ADH secretion despite serum osmolality is low. In fact, when there is low serum osmolality, there is suppression of ADH secretion, so that more free water can be excreted in the urine. But in this condition, despite serum osmolality is low, there is high ADH amount in the serum, and that leads to further water reabsorption from the collecting ducts. You know what is the function of ADH? ADH, its function is reabsorption of H2O from the collecting tubule. What is the function of aldosterone? Sodium and water retention from the tubules. What is the function of natriuretic peptides like brain natriuretic peptide, atrial natriuretic peptide? Excretion of sodium in the urine. So when there is increased ADH secretion, this leads to more free water retention in the extracellular compartment. So let's suppose this is extracellular compartment of a human system, and this much water is present, free water, and there are many osmoles in the extracellular space like sodium, urea, uric acid, creatinine, and variety of others. So let's suppose this is the extracellular compartment, and if it expands to this much, by this much, let's suppose it expands by this much. So initially there was 5 liter, now let's suppose it expands to by 2 liter, and it becomes 7 liter total free water. Then what happens? These all solids become diluted. So if you see the serum uric acid level, you can find the low serum uric acid concentration. If you check the sodium concentration, this is low. If you check the urea concentration, you find low, because there is increase in the free water in the extracellular compartment. So when there is increased free water in extracellular compartment, then what occurs in response to that? ADH is normally suppressed in response to that. But in this condition of SIADH, this suppression cannot occur because there is high ADH concentration. So body thinks that, oh, I cannot suppress ADH. Now how can I eliminate free water from my body? So let me think. Is there any way to eliminate free water? Oh, I got one trick. Let's excrete sodium in the urine. So I know that water will follow the sodium. So let's throw sodium in the urine. So it suppresses the plasma renin activity, aldosterone system, suppresses plasma renin activity, aldosterone, and secretes natriuretic peptides like BNP, ANP. BNP, ANP. This leads to increased sodium excretion in the urine. So more sodium are excreted in the urine, and water follows that sodium. So despite water follows the sodium, there is more excretion of sodium compared to water. So sodium is lost more than free water in the urine. That's why in this condition what occurs that, you know, there is expansion of extracellular space, so sodium is diluted. So decrease sodium concentration, and when there is more sodium excretion in the urine, what happens? It falls more. So sodium concentration starts decreasing more and more in this condition. let's suppose this is a person with SIADH. Normally, a person can lower his urine osmolality to 40 to 100 milliosmol per kg. But this person with SIADH, let's suppose he cannot lower his osmolality, urine osmolality to less than 750 milliosmol per kg. And he consumes diet of, let's suppose, 750 milliosmol. Thus, it produces urine amount of 1 liter. He cannot produce urine more than 1 liter. If he consumes, let's suppose, 15 liter free water, if he drinks 15 liter free water, he cannot pee out urine proportionately. So all this water accumulates in the extracellular compartment. So to eliminate more water, what he has to do? He has to increase the solute. He has to consume more solute. If he consumes 1500 milliosmol solute, it becomes 2 liter. If he consumes 2200 milliosmol, he pee out 3 liter. So he cannot change the denominator because he cannot lower this to less than this because of his this disease, SIADH. But he can only modify the numerator. He have to consume more solute. You have to increase the serum osmolality to produce more urine output, to throw out the excess free water from his body, from his extracellular compartment. Okay. Now let's talk about types of SIADH. So basically there are 5 types of SIADH: A, B, C, D, E. Type A occurs in conditions like bronchogenic carcinoma, where there is increased amount of ADH level, and increased ADH level leads to more free water retention. This lowers the serum osmolality, and this low serum osmolality cannot suppress ADH, so there is again more ADH secretion. Then again serum osmolality decreases, serum sodium concentration decreases. So this is type A SIADH. So if you check the serum ADH, it is high. But let's suppose the serum ADH is normal, but the picture is like SIADH, then that falls in type C. This also occurs in some carcinoma, like lung carcinoma or ovarian carcinoma or variety of other carcinoma. And what is type B SIADH? To understand type B SIADH, you have to understand this graph. Let's suppose this is x-axis showing serum osmolality, and this is the serum ADH concentration. So this is in terms of picogram per ml. So this is 0, 3, 6, 9, 12, and let's suppose this is 280 milliosmol per kg. This is 270, 260, 290, 300. So initially there is low amount of ADH in the serum. But normally what happens that when it crosses 280 milliosmol per kg serum osmolality, then ADH peaks. There is sharp increase in ADH level. Then it falls below 280. What happens that the serum ADH is inhibited. So there is low amount of ADH. But when osmolality increases more than 280, then there is sharp increase in serum ADH. In type B SIADH, what occurs that this osmostat is shifted to lower side. Let's suppose this is osmostat is shifted to 270. Then when it becomes 270, then there is sharp increase in ADH. Normally this occurs, but with reset osmostat, there is increase in ADH even at the lower serum osmolality. This is type B SIADH. Why do you need to know type B SIADH? Why it is different from other types of SIADH? Because in this type of patient you see the serum sodium concentration is like 125, 130 in the lower range, but it does not decreases more than this. Because when it decreases more than 270, I mean when it falls more than 270, then ADH becomes suppressed. So the serum sodium cannot fall more than this. So you don't need to worry that I need to give 12-haptan, conivaptan, or I need to give 3% sodium chloride, I need to do aggressive management. You don't need to worry much about. This is reset at lower range. So that's why it is called a reset osmostat. This is type B SIADH. Now type D SIADH, it is called syndrome of inappropriate ADH secretion. No. It is called nephrogenic syndrome of inappropriate antidiuresis. Nephrogenic syndrome of inappropriate antidiuresis. Here, if you check the serum ADH concentration, it is in the physiologic range or normal range. But you see the picture like SIADH. So you may be thinking that, oh, ADH is normal, there is not inappropriately high. Then how does SIADH occurs? Yes, SIADH acts on vasopressin receptor. So even let's suppose there is normal ADH level, but if there is constitutive activation of the vasopressin receptor, constitutive activation of vasopressin receptor due to genetic mutation, then more water is retention occurs. Despite ADH is normal, more water retention occurs. This is called nephrogenic syndrome of inappropriate antidiuresis. Why it is called nephrogenic? Because V2 receptors are present in kidney tubules. So nephrogenic and syndrome of inappropriate antidiuresis. The picture is like SIADH, but ADH concentration is normal. Now the last type is type E SIADH. Type E SIADH, in this condition there is exaggerated change in serum ADH in response to change in serum osmolality. So even if there is slight change in fall in extracellular space, there is large increase in the serum ADH. If there is slight expansion of extracellular blood volume, then there is sharp decrease in ADH. So this is exaggerated physiologic response. This is called type E SIADH. So what are the etiology of SIADH? One is infection. Infection of either lung or central nervous system like meningitis, encephalitis, brain abscess, tuberculoma, toxoplasmosis, or cerebrovascular accident like ischemic hemorrhagic stroke, subarachnoid hemorrhage, head trauma, drugs like tricyclic antidepressants, SSRI, congenital malformations like agenesis of corpus callosum, cleft lip, palate. So there are a variety of conditions where you can see SIADH. But specifically, you have to be concerned in the CNS pathology. Why? Because let's suppose I am illustrating this with an example. Let's suppose a patient is of hemorrhagic stroke, and if you check the serum sodium, let's suppose serum sodium is 120, and he has altered sensorium due to low sodium, and maybe might be also the hemorrhagic stroke part. So low serum sodium concentration. So you think, what is the cause of low sodium concentration? Can be due to SIADH due to this, or another condition is there called cerebral salt wasting. When there is hemorrhagic stroke or other CNS pathology, what happens that more salt is excreted in the urine. Salt is excreted in the urine, that is called cerebral salt wasting. Salt wasting due to pathology in the cerebrum. So So you need to differentiate SIADH from cerebral salt wasting. Although cerebral salt wasting is less prevalent than SIADH, but you need to differentiate. Why you need to differentiate? Because the treatment is different for both. Obviously, you can give 3% sodium chloride in both, it works for both, but other treatments are different here. Like fluid restriction. You know that we do fluid restriction in SIADH here, but you don't do fluid restriction here. Because here salt wasting is occurring, and with salt, you know, water also follows there, so extracellular fluid compartment is low. So you don't restrict fluid. Here instead you have to give 0.9% sodium chloride to expand the extracellular space. But here you don't give 0.9% sodium chloride, because you know that there is already extracellular fluid compartment is expanded. And if you more expand this extracellular fluid compartment, serum sodium falls more and the condition aggravates. When you are confused, you don't know whether it is due to cerebral salt wasting or SIADH, you give 3% sodium chloride because it can be beneficial for both. You need to differentiate this. How can you differentiate? Person with cerebral salt wasting has salt craving because there is more salt loss in the urine, and there is dehydration due to depletion of extracellular compartment, which are not present here. Instead, here there is euvolemia or increase in extracellular compartment, increase in free water in extracellular compartment. If you see the urine sodium, it is, let's suppose it is greater than 40 here, it is greater than 150 here. More salt is lost here. So urine osmolality, if you see, it is more compared to SIADH. If you see serum sodium is low in SIADH. And this is also serum sodium is low in cerebral salt wasting because there is salt wasting is occurring. If you see serum uric acid level, due to contraction of extracellular space, serum uric acid concentration increases. But here, due to expansion of extracellular space, serum uric acid concentration decreases. So you now know the difference between cerebral salt wasting and SIADH, and why do you need to differentiate both conditions. So we learned definition of SIADH. We learned about pathophysiology of SIADH. We talked about etiology of SIADH, types of SIADH, and then we talked about how to differentiate cerebral salt wasting from SIADH and why do you need to differentiate. Now, let's talk about treatment of SIADH. So you know that extracellular compartment is increased with free water. There is more free water in the extracellular compartment. So what is the treatment? If the patient is mildly symptomatic or asymptomatic, you restrict adding more water. So fluid restriction initially. If patient is symptomatic with low serum sodium, then you can give 3% sodium chloride. You know that when you give 3% sodium chloride, it increases serum osmolality. And due to increased serum osmolality, what happens? Patient can pee more urine. Patient can form more urine, and thus this extracellular compartment free water decreases. Other treatment is ADH antagonist like 12-haptan, conivaptan, 12-haptan, conivaptan. And apart from all these, you can give oral urea as well. The main thing is that you increase the solute concentration in the extracellular space to increase the serum osmolality. If you increase serum osmolality, what happens? Patient can pee more free water in the urine, and if he can pee more free water, he can decrease the free water from his extracellular compartment. So this is all about SIADH in a nutshell, and I hope it helps. If you have any questions or any concerns regarding this topic, you can comment it down and I will be happy to answer it. Thank you.